Good morning. I'm Amy Rowling McGee. I'm the president of the Health Policy Institute of Ohio. We're so happy that you have joined us for today's forum focused on protecting young Ohioans. During today's forum, we're going to explore strategies to improve mental health for children and adolescents here in our state. HPIO is an independent, nonpartisan, and nonprofit organization. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending here in our state. I want to thank our core funders whose steadfast investments in our mission and enable us to do our work. And then I also want to thank our forum sponsors. These are all of the series sponsors for 2022 whose generous support makes possible these online forums. I want to encourage you to tweet throughout today's forum or use the social media of your choice to share the information that you're learning and make sure that others know about this important program and the content we will hear today. If you have questions for any of the presenters, please feel free to type them into either the chat box or the question box, and we will consider those questions as time permits. The presentation slides and other related resources are posted. Actually, Alana, are they already posted on our website or will they be posted shortly?
They're up.
Okay, so all the presentation slides that we've received are on our events page on the HPIO website. If you'd like to share those with other folks or download them for future reference, you can do that through our webpage. We know that our mental health is a core component of our overall health and well-being all throughout our life course. Recent trends show that children and adolescents are experiencing increasingly poor mental health outcomes, including depression and death by suicide. However, we know that improvement is possible. These trends are not inevitable, and that there are strategies and policies that we can put in place to improve mental health for young Ohioans. Today, our speakers are going to share more information about recent data trends. They're going to share recent research, and then also talk about potential strategies and policies that we could put in place to reverse these trends. First today, though, we're going to focus on a program that is already in place. Just recently, the Ohio Department of Medicaid launched a new program called Ohio Rise for youth with complex behavioral health needs. We're pleased to have Marissa Weisel with us. She's the Deputy Director of Strategic Initiatives at the Ohio Department of Medicaid. And we also think Kelly Smith, who's the Ohio Rise External Affairs Administrator, is also on as well to share some information about Ohio Rise and about the program launch. Marissa, thank you so much for joining us. I'll hand over the slides to you now.
Thanks so much, Amy. Great to be with you all this morning. All right. So many of you are familiar with the new Ohio Rise program that launched on July 1st. Ohio Rise stands for Resilience Through Integrated Systems and Excellence, and it is a new Medicaid managed care program for children and youth who have the most complex behavioral health challenges within the Medicaid program. Ohio Rise came about after Governor DeWine took office and charged his child-serving state agencies through the Children's Initiative to really look at who we were jointly serving and try to improve outcomes, particularly when we were all putting resources toward the same kids and families. When we thought about developing Ohio Rise, we looked at some of the outcomes for kids who are served in Medicaid and by other systems such as child protection. Back in 2019, 13% of kids in the child protection system were living in congregate care settings where they were receiving treatment. And for kids over age 15, that number increased to over 40%, a greater percent than those who were living in foster care. We also knew we were sending kids out of state to receive the most intensive types of behavioral health treatment, where back in 2019, nearly 700 children had gone out of state to get this kind of care, and this number is now up near 900. We took a deep dive into our data to see if we were serving the same kids across multiple systems. For example, the kids who were receiving Medicaid, but also were receiving intellectual or developmental disability services through their local county boards, how many of them might be having behavioral health challenges? And we found out 58% of kids were taking a behavioral health pharmaceutical, some of which might have been used for another purpose, but it gave us a good sense that a lot of kids in our developmental disabilities system also had behavioral health challenges. We also thought about kids in the context of their families. And using a matched data set, we were able to understand that for kids in Medicaid, 38% of them have families who have a challenge in the substance use disorder or mental health space as well. That could be parents or siblings. All of this told us that our kids really needed something specialized to treat them better, to improve their outcomes. Sorry about that. We also looked at what some other states were doing to better serve kids who met some of the statistics on the previous slide. And what we found out was other states were better serving these kids by providing them with a different kind of more intensive community-based care coordination that was driven by kids and families, the kind of care coordination that when families talked about how they felt about being involved in that care coordination, they felt empowered and like they were better able to navigate systems, but also the kind of care coordination that was associated with decreases in hospitalizations, as well as some of the other kinds of services you would hope might not be in a kid and family's life, like going to the emergency room on a regular basis for mental health needs. We also looked at our service array in Ohio Medicaid, and we saw that there were some services that were really serving our kids well, but also we had some gaps in care. And so we built Ohio Rise. Really, before the pandemic, it was very much needed. And we saw that our current system, our pre-July 1 system, offered a really wonderful array of lower intensity services as well as out-of-home services. But what we were missing were the intensive in-community services, that really intensive care coordination that's very pro-kid and family, intensive in-home therapies, and crisis intervention. And so the purpose of Ohio Rise is to deliver specialized services and supports to kids who need these more intensive services, and to make sure that this is done in a really responsible way, where we concentrate our efforts through a single managed care entity that can work to build up capacity for these services, as well as over time to make sure that we're improving outcomes. Starting on July 1st of this year, just over a month ago, we implemented Ohio Rise. Its main purposes, again, are to coordinate care across multiple systems to really deliver on the governor's charge to say, how can we all serve kids who are receiving services from our multiple systems better, to offer new and improved behavioral health services, and perhaps just as importantly as the other, to prevent custody relinquishment, which many of you know has been a focus of our legislature in recent years, as well as a wonderful effort from our advocacy community involving parents who have been through this heartbreaking experience of giving up custody of your child to the child protection system solely for the purposes of getting them access to care, not because of any fault or abuse or neglect of the parents. Ohio Rise is for kids who are eligible for Ohio Medicaid. who are ages 0 to 20. And because this is a really specialized and intensive program, and we want to make sure we're responsible with our resources, to be an Ohio Rise, a child or youth needs to require significant behavioral health treatment. And that's measured through a child and adolescent needs and strengths assessment, or by evidence of being in a recent inpatient admission or psychiatric residential treatment facility for behavioral health purposes. I mentioned a couple minutes ago the kind of care coordination we want kids to have that's really pro-family and very community-based. So Ohio Rise introduced a new kind of organization in Ohio. We broke the state up into 20 different regions called catchment areas. And our partners at Aetna Better Health of Ohio, that's our managed care partner for Ohio Rise, they went through a selective process to select new care management entities. These are places that deliver that high fidelity wraparound care coordination, as well as work around their catchment area to say, what do we have here that could help families and kids who are serving in the Ohio Rise program, to say, these are the gaps and these are our ideas about how we could fill them in. And they're not looking in their community just for Medicaid services. They might identify that they're missing a crisis provider, or they have challenges accessing intensive in-home services. But they're also trying to think about how can we leverage non-Medicaid resources, the kinds of resources that can stay with a kid and family over time, coaches, trainings, camps, these kinds of activities that aren't necessarily billable to Medicaid, but are really lasting for a family's support. And they make sure when they're doing care coordination that they are offering these kinds of supports to the kids and families, as well as engaging them in something that, again, can last them after they are disenrolled from the program. We've got a map here, and I know the slides will be sent out. This is a listing of your local care management entities. These are really the go-to places. If you have questions about Ohio Rise, they can help answer them, and they can tell you about the kids that they're working on today. Since we've launched, we've already started providing high fidelity wraparound to the kids and families in our communities. We've been helping to assess their needs as well as pull together people who can help them. And that's, again, this really intensive care coordination process involves a dedicated care coordinator for each child and family enrolled in Ohio Rise. And it's their job to talk to the kid and family about, what do you need? Who are the people who you trust? Do you have a caseworker in the child protection system, or do you have someone in the developmental disability system? Do you have someone in your school? And to pull all those folks together, as well as to work with treatment providers so that everyone can develop a single plan together. Before, each of these systems around the kid and family probably had their own plan, and they might not have been connected. And one of the purposes of Ohio Rise is to bring these plans together into a single one that is child and family friendly, that they can refer to, and then to use that plan also to help inform everyone else's plan around the circle, and to keep everything in alignment so that kids and families aren't trying to figure out, who do I go to for what? Since we launched on July 1st, we started off with a number of kids who we were able to automatically enroll in the program so that we could proactively start working with them. We started out with about 5,600 kids. We've started those care coordination activities, and our care management entities and our partners at Aetna have been working on conducting child and family team meetings to figure out, what does a kid need now? We've also been working really hard to make sure that we can identify new kids who might need to be in Ohio Rise. And one of the best ways for us to do that is to have an assessor assess their needs. And these are child and adolescent needs and strengths assessors. We have an IT system that we built especially for Ohio Rise, but it's not just for Ohio Rise. It also can be used by our partners in the child protection system and by our partners in the developmental disabilities system, so that each child can have one assessment that can be used across systems. This is sort of groundbreaking in Ohio. We're really excited about it. And right now we have over 1,000 assessors who've signed up to use this system, who've all committed to working across systems and to helping assess kids for the purposes of Ohio Rise. We've had over 22 assessments submitted into the system. So that means for those kids who have an assessment, we're starting to understand them and what they need, as well as what the strengths are that we can build on for their care. And we've upped our enrollment to over 6,500. Since you'll get these slides, I won't go into this in detail, but we have a number of communications tools that you might find helpful as you work in your communities. We have a brochure that can be provided to children and families about what Ohio Rise is and why they might benefit from it. We have that available in English and a number of different languages. We also have on the same website that's linked here, special flyers and resources for our CANS assessors to help them understand their role in Ohio Rise, and a brochure for community partners so that you all can get out and talk about why it's important to make sure that we're referring kids for assessments and getting them into the program. Oh, here's our community partners flyers, which, we've got an overview here of what's Ohio Rise, and it can be handed out to anyone if they're interested in learning a little bit about Ohio Rise, and it also has some resources for learning more. So that's where we are with Ohio Rise. A month in, we think things are going pretty well. We've certainly had bumps, and we don't expect that we will not have more of them. With a program that is transformational and being rolled out across 88 different counties, which have multiple systems present in them. We've done a lot of training to date. We're really excited about how things are going, and we're really interested in digging in at the ground level to make sure that communities are partnering to implement Ohio Rise in their each of their own special ways.
Thanks, Marissa. I have one question just to get things started, but please, everyone who's on, feel free to type your questions in the chat or the question box. You just mentioned some bumps along the road. What would you say have been, I guess, the one or two lessons learned so far, now 1 month in?
It's a great question, Amy. One of the biggest challenges that we've had is actually not an Ohio Rise specific challenge, but it does give me an opportunity to put a plug in for some of Medicaid's other work. So I mentioned that we proactively enrolled about 5,500 kids into Ohio Rise for July 1st. And we went through the process of mailing out information to them, sending them new Medicaid ID cards. But unfortunately, the contact information that we have for many of our Ohio Medicaid enrollees is pretty outdated. And this is because of the public health emergency. During the last 2.5 years, we have not had people engaging with the Medicaid eligibility system in ways that has them frequently updating their contact information. And it's really important that we start having people do that in advance of the end of the public health emergency. It's really been a good challenge for us to see, just how outdated some of our contact information is, and it is impacting our ability to get in touch with those initial day one enrollees. It's also provided us with an opportunity to be really creative about other data sources we can use. So we're having our managed care partners, some of which have more updated contact information assist. We're also thinking about how behavioral health partners in the community can help us get in touch with kids who we just don't have good contact information for, but a recent therapist might have better contact information for.
Okay, great. And then just one other, I posted a link to the flyer in the chat. One of the things that I guess looking at it, there's a lot of language in here that I think could seem overwhelming to a family. It's overwhelming to me. And I could, putting myself in the shoes of a family that's in crisis, understanding what all of this means could be challenging. I'm wondering if there's a simplified version of the flyer, something that kind of distills the program to its essence that could be provided to families.
There is, and the flyer that you linked to is actually for community partners. The brochure, which is available in a number of different languages, is intended for kids and families. Now, I'm not going to say that we've done a perfect job of simplifying things for a family, and we're still working on that. As we engage with kids and families, we've had an opportunity to learn about what they find is most helpful too.
Okay, great. And then we have a question, does Aetna lead in identifying youth or the coordinating community-based organizations?
Great question, Susan. It's really all hands on deck. It's up to all of us to help identify the kids and families who might benefit from Ohio Rise. It might be a pediatrician who's interacting with a family where they see that challenges are escalating over time and they know about Ohio Rise and could refer for an assessment. Certainly Aetna and the care management entities are doing this work across the state and in their communities. We think schools will be really good partners in this once they start up again in the fall. We think our normal behavioral health treatment providers are also going to be great sources to help us understand who could benefit from Ohio Rise.
Okay, great. And then a related question, will education advocates be able to access care coordinators to assist with truancy issues related to House Bill 410?
I will not pretend to be a House Bill 410 expert, but have the gist of it. Ohio Rise is intended for kids who have behavioral health needs. I would imagine that a number of children who have truancy issues do have behavioral health challenges and are in the Medicaid program. And the best way to assess whether or not Ohio Rise might be appropriate for those kids is to get one of those children a CANS assessment. And we do hope that our education partners, some of them might even have CANS assessors in the schools.
Great. And then I know that Alana is going to tell me that it's time to move on, but there is one question that I want to ask that one of the participants posed, and that's, what is your evaluation strategy and measurable outcomes? Or maybe you could just point folks to where to find that.
There's quite a bit. We have a partner in a center of excellence that's helping to do training that will help us understand our kid and family engagement outcomes. Additionally, since this is a Medicaid managed care program, our managed care partners at Aetna will be measured on a variety of cross-system outcomes. Some of them are the traditional healthcare HEDIS measures, but some of them are actually more in the cross-system space. So third grade reading levels, kindergarten readiness, reductions in out-of-home placements. These are all things that Aetna is accountable for, and those metrics can be found in their provider agreement with the Department of Medicaid or their contract.
Okay, great. Thank you. Well, thank you very much for joining us, Marissa. There's a lot more information available on Ohio Medicaid's website, and we'll make sure that we include links on the webpage for today's forum so that those are all handy for everyone who's on today's webinar.
And
Thanks,
Amy,
Amy.
I'm going to ask Marissa or Kelly, if you want to get to any of the questions in the Q&A box, you can do that before you hop off, and then we'll have a little more time for Q&A later as well.
Great.
Happy to.
you.
Thanks so much.
All right, well, let's move on to our next speaker, who is Karen Howard. Karen, are you with us? There you are.
Hi, I'm Karen. Thank you so much, Amy.
Hello. Karen is the Director of Policy and Advocacy with Mental Health America. She works on both federal and state policy, manages conferences for the Regional Policy Council at Mental Health America. She has her bachelor's degree in political science from Spelman College. Thanks so much for joining us today, Karen.
Thank you, Amy. As she said, I'm Karen Howard. We're actually running our Regional Policy Council meeting simultaneously, so I stepped out of that meeting to join you guys briefly today. I thought it was really important to share, but I appreciate the timeliness, and we'll hop right back into that once this is over. So I'm glad to learn a little bit about the Ohio Rise program, which I've certainly heard of and looked into, since it will certainly help youth in Ohio. And now I'll talk a little bit more about data about how youth are doing mental health wise across the country during the pandemic, and a bit about the school-based workforce and school-based interventions that we would suggest, and the largest sources of federal funding for carrying out these school-based mental health supports and services. So you can go to the first slide. Next slide, please. So at the end of last year, it was clear national recognition came towards the mental health crisis. In December of 2021, the Surgeon General issued an advisory on the youth mental health crisis, which includes the graphic you see here on factors that impact the mental health of young people, as well as older adults, but young people included. Factors like age, individual factors like age, familial factors like financial stability, community factors such as relationships with peers, environmental factors such as natural disasters and climate change, and then societal factors such as discrimination based on race, gender, sexuality, or how pop culture and media portray injustice in America. And just before that, in October of 2021, the leading children's health groups, especially health providers, issued a declaration of a state of emergency in children's mental health. So that was the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, and the Children's Hospital Association, all of which have a presence in Ohio. And they both issued policy forward, all three of them issued policy forward documents in the form of a declaration with considerations for lawmakers, regulators, and any public official to work on. Next slide, please. So the CDC put out data in April, and this CDC data was exclusively targeted to survey high school students. Sorry for moving around a bit. I have a little sick dog here today. But the data showed that in 2021, more than a third of students reported experiencing poor mental health during the pandemic, and 44% reported they persistently felt sad or hopeless during the past year. A majority of these students reported abuse or trauma at home, including over 55%, which experienced emotional abuse, and 11% that identified reporting physical abuse. There's also racism, of course, we know impacts mental health. So more than a third of US high school students felt they had been treated badly or unfairly at school because of their race or ethnicity. In particular, Asian, Black, and multiracial students reported the highest levels of racism, and were less likely to feel connected to people at schools. There was already a crisis in unmet youth mental health needs prior to COVID, and data has shown that LGBTQ and female youth have disproportionately higher levels of poor mental health overall, as well as self-harm and suicide-related behaviors. Combine their distress with falling into the Asian, Black, or multiracial category, and you can ensure compounded worse mental health. This is really important information, not only for lawmakers and regulators to know, but also educators, principals, teachers, and educators. Next slide, please, data by race. So as you can see here, SAMHSA data over the last decade show an increase in youth ages 12 to 17 reporting major depression. And in 2020, COVID-19 added fuel to the fire. This is especially apparent in multiracial youth, indicated by the purple line that goes nearly vertical in 2020. Next slide. So in addition to CDC data and SAMHSA data, MHA also collects its own data. We have an anonymous online screening tool that anyone with a browser can access at mhascreening.org. And for those specific and mental health data that for screeners in Ohio at the state level or county level, you can use MHA's data mapping dashboard, which displays prevalence of either suicidal ideation, depression, psychosis, or PTSD based on what you select. And 45% of these screenings are taken by youth ages 11 to 17 years old. You can see in the map here that Champaign and Jackson counties have the highest rates of positive screens for depression. And there are findings for other conditions in the website. To view more of this data is mhanational.org/MHA mapping. Next slide. The 45% of 11 to 17-year-olds represents a significant increase, over 16% higher than the 11 to 17-year-olds who took a screen in 2019, when they made up only 29% of screeners. You can see that in the orange that reflects 2019, gray reflects 2020, and turquoise reflects 2021. This is a graph showing the percentage of screeners by age and by year. Also of significance is the fact that the largest increases in the people scoring positive from 2019 to 2021 were on the parent and youth screens. And what MHA found is this indicates a large increase in the percentage of youth experiencing emotional, attentional, or behavioral difficulties during the pandemic. So not only did more youth take screens during the pandemic, they were also more likely to screen positively with a condition than other demographics. Next slides. In this slide, we see that suicidal ideation is highest among youth. Rates of suicidal ideation for LGBTQ youth are highest, followed by female and Black youth. Black or African American screeners had the highest rate of increase in reported suicidal ideation during the pandemic, 2019 to 2021. And this is actually a trend that was found even before the pandemic started in data collected by NIH and others. The Congressional Black Caucus Emergency Task Force on Black Youth Suicide released a report at the end of 2019 highlighting this, recommending policy changes. And then subsequently, the chair of the task force, Representative Bonnie Watson Coleman from New Jersey, introduced the Pursuing Equity in Mental Health Act, which created funding and research for more trauma-informed services for Black and Brown youth, as well as creating a pipeline of culturally sensitive and responsible professionals. That bill did pass the House of Representatives last year, but unfortunately has not yet passed the Senate. We'll see if it's included in any upcoming package. Among youth that scored positively, the top 3 contributors to their mental health problems were loneliness or isolation, past trauma, and relationship problems. Considering CDC data from the earlier slides about the impact of racism and feelings of belonging, fair treatment in schools seems to correlate to student mental health as well. And feelings of isolation and loneliness often lead to substance use. So it's really important that we get to these things early. Next slide. Slide 7 just shows some of the differences and concerns across race and ethnicity. Black screeners cite financial insecurity and racism. Native and Indigenous screeners report more past trauma as impacting their mental health today. Asian and Pacific Islander screeners worried more about COVID-19, and Hispanic and Latinx screeners cited loneliness or isolation most. Multiracial screeners identified loss and grief most often. Next slide. So I'll transition a little bit more to workforce issues. So for instance, the American Psychological Association reported a large increase in demand for treatment of anxiety and depression in 2021 compared to previous years. And the health provider workforce still has a shortage. There's a behavioral health workforce shortage. So psychologists and other mental health professionals are asked to do more currently and serve more people. However, there's not as much safety net and workforce growth that there should be to meet the needs of populations. More than 8 in 10 psychologists who treat anxiety disorders saw an increase in demand for anxiety treatment. And then about 7 out of 10 psychologists who treat depressive disorders say they've seen an increase in demand. Next slide. Shortages of school-based mental health professionals are included in that behavioral health workforce shortage, and this existed prior to the pandemic. Research shows that school-based mental health providers like counselors, psychologists, social workers, they improve school climate and other positive outcomes for students, such as in attendance, suspension and disciplinary incident decrease, lower rates of expulsion, improved academic achievement and career preparation, and improved graduation rates. The recommended ratio of school psychologists is 1 to 500 students, and the current national average is almost 3 times as much at 1 to 1,400 students. Other mental health professionals in schools, such as counselors and social workers, have ratios that are similar. No state meets the requirement for school social workers, but a few states do meet the recommended ratio for school counselors. The national average of social workers to students is nearly 8 times greater than recommended ratio at 1 social worker to every 2,100 students. At this time, I'm hoping that in the chat, there is a link to the Hopeful Futures campaign report cards. This is a national group, and they put out back in February a report card of every state and evaluated whether or not that state had 8 points of, I think I'll talk about this a little bit later in the presentation, but they evaluated each state on 8 points of importance to school mental health and whether or not students are served well. So please, I encourage you to take a look at this and use it as a way to advocate for better services and implement better services and supports for students in schools in Ohio. So we support prevention in schools. Next slide, please. We support prevention in schools. So beyond awareness of mental health, there's real education. And while there's no national curriculum for mental health education, there are states that have done it right. MHA proposes to address mental health issues in students through multi-tiered systems of support, and the Department of Education is well aware and supports this. And the multi-tiered systems of support include mental health promotion at the first level, tier 1, targeted prevention and early intervention, tier 2, that's screening and possibly non-clinical support. And then 3, the third tier, is treatment through services, which should be for a much smaller group of people. While promotion and prevention and early intervention would kind of be population level and all students should get that. In a July 2021 report, MHA highlighted the mental health education, services, and supports. And when we say supports, we mean things like excused absences for mental health or mental health sick days. These 3 things are important to the puzzle. This report may be found on our website at nhanational.org/youth in crisis. The goals of mental health education are to help school personnel and students understand mental health and mental illness and what contributes to both. They're on a spectrum, mental health, we all have mental health. Some of us get to the point where on the spectrum, we become kind of deteriorated to mental illness. And so, at any point we may go across that spectrum. To improve comfortability using terms to describe mental health and mental health conditions, including mood, anxiety, depression, psychosis. This is also an objective of mental health education. Also to encourage help-seeking behavior and knowledge of where and how to initiate care and support is an objective. And finally, to increase understanding of treatment and support options where there's shared decision-making between a person experiencing distress and their provider, whether it's a counselor, psychologist, or psychiatrist. Next slide. New York and Virginia were the first two states to pass mental health education laws requiring K through 12 schools to teach mental health education. And beyond education efforts, services and supports are now implemented in Kansas, Minnesota, and Oregon. Next slide, please. One of the most effective policy changes for providing comprehensive mental health services through schools has been through establishing partnerships with community-based providers. These programs eliminate the need for transportation, parents having to take off work, wait times, and other barriers. Youth are also more likely to complete treatment in schools compared to other settings, especially Latino and Black youth, who are more likely to only receive these services in schools. So it's an equity issue as well. Kansas's mental health intervention team has had successful outcomes due to the legislatures providing support for school districts to partner with community providers and through their creation of a payment mechanism to fund these services. As you can see, attendance, internalized and externalized behaviors, and academic performance all improved. And note that having data is integral to tracking progress. And then finally, on the last slide, I just wanted to highlight a couple of federal funding areas that can support states. There is, through the American Rescue Plan, one of the many COVID relief packages, there was funding that was available to states. And now more recently, through the Bipartisan Safer Communities Act, a gun violence compromise bill, which includes money for mental health that was signed into law or enacted in July. Both of these bills have billions of dollars in funding for mental health. And just by the way, we try not to conflate violence with mental health conditions because people with mental health conditions are more likely to be victims of violence. And that's what research shows, except the connection comes into place when we talk about suicide, as over 60% of gun deaths are suicides. So it's really important to lock those guns up, keep them safe, away from people who might use them. And also there's other kind of prevention methods included in that compromise bill that you can look into. So the Education Department has several pools of money through the Every Student Succeeds Act and several titles. So if you look at the title for professional development, so yes, teachers, administrators, others, faculty, staff around the school, all those adults need to be invested in. Their mental health needs to be invested in so that they can be supportive for kids. The number one indicator or factor that leads to positive outcomes for youth is having at least one caregiving adult in their life that they can rely on. And that one person might be at school. It's also important to look into school climate funding, education and awareness funding, and now there's going to be a new pot of money for a pipeline of mental health professionals that are culturally and linguistically responsive. So really excited about that new funding coming down. It's going to be over hundreds of millions of dollars. States should keep an eye out for grant notices and announcements from the Department of Education. And then next is through CMS and Medicaid. And I see I'm almost out of time, so I'll just try to wrap this up really quickly. In 2001, the free care rule lifted for school billing of Medicaid. So new guidance was announced, the administration, the current federal administration has announced that they would be giving new guidance from Medicaid on how schools can bill. And especially billing for mental health services, we would expect that many of the services students receive in school will be mental health. And they will also be giving guidance and technical assistance for how states can implement early and periodic screening, diagnosis, and treatment, a requirement under Medicaid that some states fail to implement, as well as school-based services. They're literally going to be providing technical assistance for how to set up school-based services. So you can actually find the letter and the fact sheet on departmentofelducation.gov. The letter to governors outlines all of these new guidances and new funding that will come down. And I think I can drop it in the chat here, actually. Yes. Oh, no, that didn't go to everyone. Let me try again. So I'll wrap up just by saying that SAMHSA and has Project Aware, and CDC has Healthy Schools programming. And both of these programs are funding schools around the country for various wellness and well-being initiatives that students can benefit from. And some of the Healthy Schools programs are only kind of focusing on academic performance and physical health, but we're urging states to incorporate mental health into those grants and to use some of the money for programs that would improve student mental health. Thank you so much. I'll just wrap by saying, if you want to learn, more, feel free to reach out with questions. I'm so glad to be here with you all today.
Thank you so much, Karen. That was a very rich presentation. My fingers could barely keep up with like following on the links and posting them and all of that. So once again, a reminder to everyone that the slides from today's presentations are posted on our website, and we will, there's already links in Karen's presentation that you can follow to get to various resources. We'll also be posting many of those on the webpage as well. And I'm working on posting some of them on LinkedIn as well. So that you delivered, Karen. That was great. And I know you took time out of another meeting that you're having today. So we really appreciate you joining us. Somebody commented that they can't wait to see Ohio's report card. I think it's, the data you shared is deeply troubling. Appreciate, though, you also sharing resources, strategies, and kind of a hopeful message towards the end about new resources that'll be available to eliminate the disparities and inequities and poor health outcomes that we're seeing today.
Absolutely. Thank you so much, Amy. That's a great, I appreciate the kudos. And happy to answer any quick questions that come in. Otherwise, I hope you guys all are really successful with the Ohio RISE program and continue to invest in young people.
Yes, I'm seeing tons of comments, like positive comments about your remarks. Outstanding information, great information, so much important information. I'm not seeing any questions. Stephen, are you, or Alana, are you seeing any questions for Karen?
I don't see any.
Okay, great. Well, thank you so much again for joining us. We'll let you get back to your other meeting.
Thank you so much. Have a wonderful rest of your day.
All right, thank you. We are going to have a poll question here. So we're going to take a little tiny break. Please feel free to stretch a little bit, move around some. And in the meanwhile, I will ask Alana to put up the poll question. We'd appreciate everyone's participation in the poll. So this is the poll questions are focused on our first two speakers of today. The first question is, as a result of attending this forum, I have increased knowledge of Ohio Medicaid's new program, Ohio RISE. Please give us our feedback on that. And then also the second question relates to our first speaker. So how would you rate the quality of our first speaker, who is Marissa Weisel? And then, Alana, I'll wait for your signal that you're closing that poll. And
that's okay. There's two more in there. So just make sure you also answer the questions about Karen, who just wrapped up.
Oh, I didn't scroll down.
That's okay.
Okay,
that's
so
a good reminder
down,
for everyone. Go ahead and scroll down.
You go down to questions 3 and 4 too. As a result of attending this forum, I have increased awareness of the state of mental health for young children and adolescents, both in Ohio and nationally. And then fourth question is, how would you rate the quality of our second speaker, who was Karen Howard from Mental Health America?
All right, we'll give everybody just another minute or two, Amy, to close out those polls, and then we'll move on to our next speaker.
Great.
But yeah, just thank you for the reminder to stand up and stretch. We've got about another hour ahead of us, so we just want to make sure that everybody's moving.
Yeah, do a few shoulder rolls. Move your neck around a little bit.
Great. All right, it looks like we've got quite a few people who responded to those polls. Thank you, everybody, for doing that. We have another poll after our next two speakers, so just please continue to participate. We do appreciate the feedback.
Alana, should I go ahead with introducing our next speaker?
I think it would be a great time to do that.
All right, I'll do that. So next up on our agenda is Tony Coder. He currently serves as the executive director of the Ohio Suicide Prevention Foundation. He's been there since, I believe, 2019, maybe a little earlier than that, 2018? Oh, 2019. Okay, I got a thumbs up from Tony. He has led statewide efforts in creating the state's first suicide prevention plan, which was announced by Governor DeWine in February of 2020. Let's see, he also leads the charge to support community-based efforts in Ohio to reduce the stigma of suicide, promote education and awareness about suicide prevention, provide training and development, and increase resources and programs that reduce the risk of lives lost to suicide. Tony, thank you for joining us today.
All right, thank you so much, Amy, and thank you so much for really bringing light to this very, very important topic and the work that you do at Health Policy Institute of Ohio. You know, it's always a proud moment when you know, I'm able to say that you know, we're partnering with HPIO and the work that you do. You just do outstanding work, so I'm really, really grateful for what you and your team do. Really outstanding stuff.
Thank you, Tony.
All right.
The feeling is mutual.
Let's see.
Alana can move your slides for you if you'd like, and you can just say next slide if that's easier.
That would be absolutely outstanding.
Okay, we'll do that.
3 years into Zooms, and I still can't remember not to wear a shirt that makes people have vertigo. So you know, the lines and everything. So it would be better, yeah, if someone can control those. So thank you so much. This is suicide prevention in Ohio. Next slide, please, Alana. Just a very quick about my presentation. Suicide is not an easy subject for some. There might be some you know, some traumatic issues associated with you. If you feel that you need to leave, you know, turn down my sound, whatever you need to do. At any time, you know, my first wish is to make sure that everyone who watches this today takes care of themselves. My feelings are not hurt at all. I've been told a lot of times, you know, I'm not somebody's cup of tea. So, or, you know, so don't feel bad if you have to, you know, remove yourself. Questions, I'll do my best to answer questions, but some are medical or philosophical in nature. I'm not a clinician, and I will sometimes give opinion. I will preface that if it's my opinion as opposed to fact or research that we have here at OSPF. But I would do my best to answer questions. I also, if there are questions in the chat around, you know, we want to assume good intentions. We know that folks who have lost someone to suicide do not ever say the phrase commit suicide. Commit brings about, you know, you commit murder, you commit adultery. It's usually affiliated with a with a negative act. And, you know, we want to make sure that we use phrases like die by suicide. That's a, you know, that's a, you know, a phrase that's often used. So we want to make sure that, you know, we're all in here for good intentions, and that no one's trying to be offensive or anything else. Also, if you or someone you know is having suicidal thoughts, please call the National Suicide Prevention Lifeline within the last week. That has changed, however, to 988, much easier to remember number. And we encourage you to utilize that number, and make sure that folks that you care about, or even yourself, have that opportunity to talk with a trained crisis professional and get folks the help that they need. Next slide. All right, so suicide in the U.S. I think Karen covered a lot of this. You know, suicide is the 11th leading cause of death in the United States. We have somewhere around 130 suicides a day. Like Ohio, suicide is the second leading cause of death in youth ages 10 to 24. Ohio's a little bit different in one of those stats we'll go over in just a moment. White males make up about 70% of the suicides in the country. And you know, women have higher suicide attempt rates, to Karen's points. However, men had higher suicide completion rates, and it's for one simple reason. It's the methods used. Men usually use guns. They have a much higher rate of dying by suicide using a firearm, as opposed to women use less lethal means. However, again, women have higher suicide attempt rates. So next slide, please. So in Ohio, we have nearly 5 people die by suicide every day in the state. And that's, again, just Ohio. In 2020, according to the Ohio Department of Health, we had 1,641 deaths by suicide. That's actually down a lot. One of the more common questions I get, well, you must have seen during the pandemic, the suicide numbers climb. We know that research from the University of Washington showed that during any kind of natural disaster, any kind of national event, national tragedy, 9/11, those types of events, actually suicides decrease in the days and weeks after. It's somewhere between anywhere from 9 to 18 months that we start seeing those suicide numbers climb. Why is that? According to the research from the University of Washington, it's because folks, if you remember back to the beginning of the pandemic, we were all in this together. We were making calls to one another. We were doing things that really made it feel like a concerted and effort that brought us all together. And as things time goes on, these are traumatic events that we've been through together, but also being alone in a lot of these things. Suicides were at their highest in 2018. Over the past decade, we had 1,836 suicide deaths, and to the point of the national statistics, suicide is the second leading cause of death in youth ages 10 to 24. However, in Ohio, suicide is a leading cause of death in youth ages 10 to 14, and we're starting to see these the ages get younger and younger. Again, it's not a large number of young people. However, whenever you're talking about a 10 preteen to early teen, that really is such a tragic event, and we need to make sure that we are scaling downward as far as our ages in suicide prevention, teaching resiliency, teaching some strengths-based models in schools. Again, the majority of suicides in Ohio are adult men, and early look at 2022. where we are seeing a rise in suicides, which aligns with some of the research that I spoke about earlier. And we have nearly, in some counties, Butler County, Richland County, Mahoning counties, we're seeing near record numbers. I know that Richland County, I just talked to them the other day, have already, in the first 6 months, have already surpassed their yearly average of suicides. So we're starting to see those numbers climb up. And again, 988 is available nationwide. So that's the new suicide prevention lifeline number. Next slide, please. Karen covered a lot of this. One of the things I wanted to point out was, about 50% of folks who died by suicide have a diagnosed mental health condition. We have seen some research that showed that about 90% of folks who die by suicide have either a diagnosed or undiagnosed mental health condition. And we want, how can we look at we have folks that are psychological autopsy certified individuals across the state, as well as suicide fatality review boards that are beginning to look at that, look at those, look at some things around, what were families seeing before the suicide death? What were some individuals? Where were folks? Where were folks looking at online? So those, kind of investigations after a suicide death are giving us a lot more data and a lot more opportunities to see what we can do to prevent suicides. Next slide, please. Some of the COVID impacts, I remember seeing some of the early news reports about how, we were pretty, the state was pretty happy at the tax revenue that folks were, that they were getting around record alcohol sales. But, with alcohol and overuse of alcohol, those are not great things that are happening when someone, develops an alcohol use disorder. We also saw record overdoses during COVID. We saw at our suicide prevention crisis lines across the state, and those are both national suicide prevention lifelines, as well as some of the local crisis lines in our state, that we saw increases in those calls. We also saw increases in past month suicidal thoughts. And Karen alluded to this, the state of emergency that was issued. We also saw, in talking with the Nationwide Children's Hospital, that suicide attempts and ideations, according to some of the suicide prevention group over at Nationwide Children's, they were seeing near record numbers after kids were going back to school, which was interesting, and kind of went back to the University of Washington study. Next slide, please. The Ohio Children's Hospital Association, going back to that point of children's hospitals seeing more children for suicide attempts in their emergency rooms. The Ohio Children's Hospital Association said that, reported that between 2020 and 2021, the number of children hospitalized for a mental health reason increased 163%, which is a pretty telling tale to the trauma that youth have experienced during this time. Not just, maybe being with an abuser in their household, but, being away from friends, the upheaval of their lives, not getting to be, not being able to experience the same, school and other activities that are in their lives. So, we know that young people are experiencing higher mental health conditions and around the state, and many times that can lead to suicidal ideations. Next slide, please. Going back to suicide by means, again, about 50 to 60% of our suicides are by firearm. It is the most lethal means of dying by suicide. Suffocation, which includes hanging, is second. Poisonings, which includes overdoses, intentional use of medications, and then there are others, other means that folks use to die by suicide. What we're looking at, what we're trying to look at, and doing some research on it at the Ohio Suicide Prevention Foundation, is trying to see how we can work better to understand intentional versus unintentional overdoses, especially of opiates, because we know that, just bringing someone back from Narcan is a wonderful thing. We absolutely need Narcan used in every setting that we can get it in. However, what are those things that need to be done? If it was an intentional overdose, what kind of mental health treatment? Are there opportunities that we can share some suicide prevention resources with individuals? So understanding the intentional versus accidental overdoses really needs to be looked at. We at the Ohio Suicide Prevention Foundation, we have placed a position within the Franklin County Coroner's Office to work with suicides in Franklin County. And there's also someone who is not funded by OSPF, funded another way, that works on overdoses. So those two individuals work together to try to determine what, which are intentional, which are accidental, so that we can get better data and better opportunities to help folks who might be struggling with substance use and have suicidal ideations. Next slide, please. So we have an Ohio suicide prevention plan that Amy mentioned in the bio. We were one of the last states to not have a suicide prevention plan. So we coordinated along with the Ohio Department of Mental Health and Addiction Services and the Ohio Department of Health, the suicide prevention plan, which brought us, around 35 public and private partners to write this plan. These are the plan priorities that were developed during that time. The plan actually runs out December of this year. However, we are in the early stages of creating the next suicide prevention plan. We want to build on some of the successes that we've had on the with this plan, and also address some of the things that didn't work out too well. That it was dealing with some systems have been challenging, especially during COVID. So how can we build on that and make sure that we reach the goals that we set in the suicide prevention plan? We also work with an evaluator on this plan and have written, on our website is year one, our report on the first year of our suicide prevention plan. And we are about ready to release year two's data and some of the successes and challenges during year two. So next slide, please. So strategy one, all Ohioans will recognize the warning signs of risk factors of suicide. What we wanted to do, what the group wanted to do with this was strengthen the public's knowledge and ability to promote wellness. We wanted to make sure that folks understood how to recognize suicide, the signs of suicide, how to talk to someone who they feel might have suicidal ideations or thinking about suicide, and then how to help refer those individuals to care. So recognize, just like heart disease, cancer, any of those, the more that you know what the signs, the symptoms are, the better we're able to then deal with referring someone to care. We also wanted to, through that we've provided gatekeeper trainings like QPR and Working Minds and a number of other gatekeeper trainings. We've had Columbia University come in and do some gatekeeper trainings with community groups around the state. And again, going back to the firearms issue, we want to encourage safe storage of firearms, medication, and other lethal means. Next slide, please. Strategy 2, Ohio will concentrate efforts on integrating suicide prevention practices and suicide care, including postvention. What postvention is after a suicide, how do we make sure that systems are taking care of, whether it's a business, how do they take care of their employees, healthcare systems. And these are the 4, based on data that the Ohio Department of Health helped us to wade through. We know that healthcare organizations, 50% of people who die by suicide see their physician, their primary care physician, within a month of taking their own life. So how do we make sure that primary care physicians, emergency rooms, physical healthcare doctors, and nurses and other healthcare professionals actually are able to identify signs of suicide, help create safety plans, which are plans that are created by an individual who is struggling with suicidality, and making sure that they have access to care, plans on who to call if they're feeling suicidal. And means to, clearing out means as far as lethal means like guns and things like that. We also wanted to, and we're training right now, we got a grant from United Healthcare to train behavioral health clinicians in our state, and not only mental health clinicians, but also substance use disorder treatment providers. We've received a lot of feedback from treatment providers who deal with folks with substance use disorder, that they're seeing more and more suicidal conversations and thoughts. So we're training those individuals and identifying, how to help those individuals with some of our assisting and managing suicide risk training that is provided by United Healthcare. Education systems, not only working with schools, but, how do we work with, we work closely with Boys and Girls Clubs across the state. We work with, other, faith-based organizations on providing education to young people. And then finally, public safety. It was just announced that we are going to be training law enforcement, fire, EMTs, and other public safety and first responder individuals, and not only how to deal with someone who is suicidal, but also how to deal with folks who are within their own profession. So other law enforcement officers, other firefighters, because we know that folks who are first responders have higher suicide rates. So we want to make sure that they're protected as well. Next slide, please. Well, this is when we talk about schools, one of the largest evidence-based suicide prevention programs in the country is Sources of Strength. It is a very upstream suicide prevention program, whereas most others are almost in that intervention mode. They focus on how to talk to someone who is suicidal, how to get someone to help. This is very upstream. How do we develop those strength-based character pieces of each child, and make sure that we encourage those? We really loved, in working with the Ohio Department of Mental Health and Addiction Services, we really love the evidence-based approach to very early mental health care and mental health strengths and risks assessments that are being done. And we really thought this was, it was pricey, but through some of the ARPA money and the COVID dollars, we have been able to work with schools and other organizations to promote and give Sources of Strength for free to individuals across the state. And actually, I see the question down there. Is there a map of where Sources of Strength is integrated? Yes, and we can absolutely share that map with everybody on here. So I would be more than happy to send that out. Next slide, please. Strategy 3 is building our suicide prevention coalitions across the state. We have somewhere around 50 to 55 coalitions. We work with local ATOM boards, local NAMI affiliates, local groups. I saw that Nancy Miller from 1 in 5 is on this presentation. So we want to work with local groups and we want to make sure that best practices are used in those coalitions and groups, and be supportive of the valuable work that they do at the local level. Next slide, please. Strategy 4, this was probably during our writing cycle the most, it brought the most conversations, because we wanted to use data to break down, where should we focus, what populations. And it basically is anybody from youth to individuals, youth from 10 to 24, and then also adults. We wanted to look at veterans. Veterans have a much higher suicide rate than their counterparts, civilian counterparts. Appalachian counties, they have much higher. If you look at that map, and that was from Ohio University, looking at 10 years of suicide data, you can see the darker green. Appalachia seems to be where the highest suicide rates are. But we also wanted to allow communities to identify their own population focus. We are going to be changing that in the next iteration of this plan. Instead of focusing on just high-risk populations, instead, how do we work with systems? How do we make sure that no matter where you're, where you're at, whether you're, African-American community, which I think has seen a 164% increase in suicide in the last 2 decades, LGBTQ plus population that Karen talked about, that we make sure that everyone has an opportunity to be highlighted and focused on in suicide prevention planning. And finally, strategy 5 is about, the next slide, please, Alana, sorry, is to improve our data systems around suicide care. One of the bigger frustrations that I have is, our last complete set of data is from 2019 around suicide. How do we make sure that we have more timely data? One of the great things that the Ohio Department of Health is doing, they've put together a syndromic surveillance system that we're going to have access to, I guess, very soon, which actually they take data from hospitals that show how many suicide attempts are coming into hospital systems around the state, and that will be broken out by regions or counties in the state. So we're pretty excited about that happening. Next slide, please. And these are just some things to come, then I'll be done, because I know I went over a couple minutes. Sorry, Amy. LifeSite Ohio expansion. So working with gun shops. We've been doing a lot of working with gun shops on expanding suicide prevention work. Gun shops have been training us on gun culture, and we have also been training gun shops on identifying folks who have some of the signs of suicide, and working closely with them, which has really become such a valuable partnership. That's a whole another hour that we could present on around guns and suicide. Some of our post-COVID work, we know that to Karen and Marissa's presentations, we know that more folks are experiencing mental health crises. 988 planning, again, just released a couple weeks ago, and we have 988 in every county in the state of Ohio. We want to make sure that we expand postvention, which includes loss teams, which includes support groups and other opportunities for folks who have experienced a suicide in our state. We are going to have, starting this fall, we'll be working with the with the Health Policy Institute of Ohio around community forums for suicide prevention in the African American community, inviting African American leaders around the state to come to those and share what the experiences are and where the holes are that we need to fix at a state level. We also are creating Ohio's first LGBTQ statewide community and suicide prevention campaign. And I've talked about the other couple of things, so I wanted to get through this and answer any questions. I think that's it. So thank you so much for everyone paying attention. Again, thank you, Amy, for your commitment to suicide prevention and for hosting this event today.
Well, and thank you, Tony, for your time today and for the partnership that we've developed. I continue to learn from you about suicide prevention. We have posted, I posted a link to the most recent report from the implementation team of the focus on the suicide prevention plan. Lots of other great resources available on the Ohio Suicide Prevention Foundation website. So I would encourage folks to go there. And Tony, if you don't mind sticking around for a little bit and just browsing the Q&A and the chat boxes to see what questions folks have that you might be able to respond to virtually, we'd really appreciate that.
I will do that. Thank you.
All right. Thanks so much, Tony. Last on our agenda today, but certainly not least, we have a couple of speakers from who are working to implement the Pediatric Behavioral Health Initiative here in Ohio. This initiative was announced in May of this year by Governor DeWine and is focused on increasing access to care and expanding capacity across Ohio to behavioral health services and supports for children and young adults. We have two representatives or two entities that have received funding from the Pediatric Behavioral Health Initiative. The first is Dr. Kelly Blankenship, who is the Associate Chief Medical Officer and Division Chief of Psychiatry at Dayton Children's Hospital. And then second, we have Sherry Shamlin, who is the Chief Strategy Officer for Hopewell Health Centers in Southeastern Ohio. Thank you so much for joining us, Dr. Blankenship and Sherry. We'll go first with Dr. Blankenship, and then we'll hear from Sherry. So take it away.
Hi, thank you so much for having me. I am actually presenting from California, and there's not great Wi-Fi here. So if there's any problem, just stop me and let me know.
Looks good so far.
Okay, thank you. So I just wanted to go over very quickly an overview of what I'm going to be discussing. So I'll start with the Behavioral Health Strategic Roadmap at Dayton Children's, and this is our plan to increase behavioral health services to youths at risk. Then also the new behavioral health building that we're building. And this is what we are using the funding from Governor DeWine's Pediatric Behavioral Health Initiative. And then some current barriers to youth accessing mental health services, and then what these opportunities are to improve these barriers. And I think for Ohio, specifically with Ohio Rise, it's very exciting because I think that we are going to be able to improve some of these barriers that families and kids are facing. Next slide, please. So this is our behavioral health strategic roadmap at Dayton Children's. And so this is our roadmap of how we're going to increase services in the Dayton area and the areas that Dayton Children's serves. And so we have this broken down into 5 pillars. The first is the prevention and early intervention. And under this pillar is things like our Zero Suicide. It's also on Our Sleeves campaign. The On Our Sleeves campaign is set to reduce stigma, and it also actually helps train parents on how to talk to their kids about mental health issues, which I think is really exciting and very needed. The early intervention piece is about improving mental health access in the schools in the Dayton area, and also about improving collaborative care in pediatric offices. So integrating therapists and even psychiatrists within pediatric offices. Outpatient. So under this pillar, we're improving behavioral health access to service in the Dayton area. So we're going to be opening 6 outpatient satellite therapy sites and also improving access to psychiatrists. The crisis and emergent pillar. So currently our crisis center, when families come there, depending on the time of day, there can be a long wait. And so we will be increasing those services so that families will be able to receive care a lot quicker. Inpatient. So currently we have a 24-bed behavioral health inpatient unit. It's almost always full 9 months of the year when kids are in school, when they're under the most stress. It's rare that we have an open bed. And so this, we'll also be discussing about how we're going to increase access to inpatient behavioral health beds. And then the specialty niche programs. So these are programs like treatment for eating disorders, for treatment for kids with developmental disabilities with severe and aggressive behaviors, and treatment for substance use disorders. Because these niche services require providers with very special training, and some of them reach over into medical, so they're not just behavioral health, but there's a strong medical component like eating disorders, it can be harder to access these services. And so we're going to talk about improving access to those services as well. Next slide, please. So the behavioral health facility. So this is specifically what we're using the funding from Governor DeWine's Pediatric Behavioral Health Initiative for. So this is a $100 million behavioral health building that we are going to be building, and 25 million of that is coming from DeWine's Behavioral Health Initiative. So next slide, please. So this is what's going to be going into the building. So our crisis services, like we discussed before, so if a child is in crisis or a family is in crisis and needs an assessment, we are going to be doubling our current beds and access to this service. Our inpatient behavioral health beds. So currently we have 24 inpatient behavioral health beds. We'll be increasing to 40 beds. Actually a total of 48 beds total. 8 of those beds, though, we are exploring the option of having for kids with developmental disabilities and severe aggressive behaviors, because currently if you're seeking an inpatient behavioral health bed for a child that has a developmental disability and severe aggressive behaviors, there are no options in the Dayton area. We'll also be moving our partial hospitalization program there, so that's 30 patient slots for partial hospitalization program and 30 slots for intensive outpatient program. So it's actually a total of 60 slots. And then our bridge services, this is a new program to Dayton Children's. And so with this bridge service, if a child comes in crisis and has an assessment in our crisis center, but does not meet criteria for an inpatient behavioral health stay, or does not meet criteria for a partial hospitalization program, currently the process is that we then refer them to an outpatient therapist. Now it can take 4 to 8 weeks to get into an outpatient therapist. So with these new services, those children will be able to follow up in our bridge therapy clinic and bridge medication management clinic, where they will be seen in 24 to 48 hours after their crisis assessment, and then can be seen in that clinic until they are connected with outpatient services in the community. Next slide, please. So this is a slide just discussing the importance of and why we are locating these services in the same building. And so this is really going to be an acute crisis service building. So all of the therapists in this building are going to be cross-trained. And the point of that being that if we have a therapist go on an extended leave, it will be much easier to fill in that slot until that therapist is back. In the past, what we've had to do sometimes is limit the services we're able to give to kids if we have somebody go on an extended leave, because we don't have a provider for that service. But now with everybody cross-trained, that will be much easier. The other important piece that this does is each provider will know all of the services in the building very well. What can happen currently is that if a child comes to the crisis center, they can be referred to a different service within our system. And then occasionally when that family will connect with whatever service they were referred to. If for some reason they don't meet criteria for that service, it can be obviously very frustrating for the family, but with all the therapists cross-trained, they will know all the services very well. And so that should not be happening in the future. Also, if the family comes to this building, they will know that if they come for crisis center or if they are then admitted to our inpatient unit, they will know then that follow-up services will be located in this building if they're coming back to our bridge clinic or our partial hospitalization program. Next slide, please. So this is just a model of the building. So the crisis services and the bridge therapy and partial hospitalization program will be on the first floor. We'll have 2 units on the second floor, and the third floor will be our third behavioral health unit. Next slide, please. So the current barriers that I think are very difficult for families and youths currently when they're trying to access mental health services is, one, the limited number of mental health beds. This goes statewide. And like, I discussed earlier, we'll be increasing our behavioral health beds. We'll be doubling those. There's a limited number of residential beds. And my hope is that with Ohio Rise and the goals of Ohio Rise, that those will, that will improve access to residential beds, especially for those with Medicaid. Transportation concerns. So I think for a lot of families, it's hard to navigate or to get transportation to certain services. Navigation of the mental health system, I think, is difficult for many families. We have a workforce shortage. I think there's a workforce shortage for all providers, but I think where we see the worst or the most shortage is with the therapist and the lack of niche services. Next slide, please. And so this is where I see the opportunities, and I'm very excited about Ohio Rise because I think that this can help with quite a few of the barriers that we're currently seeing. Ohio Rise, obviously, as I discussed, will have care coordination, which I think will be very helpful, the mobile response and stabilization services. And so this, if a family is in crisis, they can call a number and a mobile response service will come to them. The stabilization services offered are typically in the home too. And so I think that will be very helpful, especially for the families that have barriers to transportation. Again, with the intensive home-based therapy, if a child qualifies for this through Ohio Rise, it's another service I think that will be great because it will help with that barrier, which I think for some families is very, it's huge, and it really prevents them from getting the services they need. The increase in residential beds, again, through Ohio Rise, I think will be very helpful for those kids that qualify for this service. And then we will be increasing the services in Southwest Ohio to therapy and medication management, acute care and crisis services as well. And the increase in services for niche programs. So we at Dayton Children's, we will be opening an outpatient eating disorders program. We're also going to open a partial hospitalization program for eating disorders. And we are looking into serving the kids with developmental disabilities and severe aggressive behaviors. And so I think increasing those niche services will be an important piece because those are, as I talked about earlier, they're difficult to find service providers because of the specialty training it requires. And then sometimes the breach over that it has into a medical component as well as a behavioral health component. So I think, I know I went through that pretty quick. I think I saw some questions pop up. I can't see them with the screen I have. Is there somebody who could read those? I'm sorry.
Sure, yeah, we're happy to. I'm just looking at them right now. Actually, I'm not seeing any. Alana, do you see any questions?
There was one question that asks, is Dayton Children's also looking at social determinants of health challenges that may contribute to mental health issues for pediatric/young adult patients to support them and or their families / caregivers?
Thank you, Steve.
That's a great question. And we actually have a separate committee that works on that. And we work with that committee specifically to address the mental health areas. It's a whole diversity committee. And so we're working with them on those as well.
And then I think I see one more that says, given the high number of suicides in Appalachian counties, is there a push to increase access to services to these counties?
So we are looking into that as well. I think a big hope for us is that Ohio Rise will help with that as well. And I think I've been talking to pediatricians too about how to improve access for those families to Ohio Rise, because I think in those counties specifically, I think because there is a mental health shortage, I think it's hard for those families and providers to know as much about Ohio Rise. And so with some of those counties, I've reached out to those pediatricians as well to help increase the knowledge of Ohio Rise and to look into what services that as Dayton Children's, especially in the Southwest area, that we could provide to them.
I think that is a great segue to Sherry Shamblin, who's the Chief Strategy Officer at Hopewell Health Centers in Southeastern Ohio, because they are serving the Appalachian area intensively. And then Dr. Blankenship, are you going to stick with us here through Sherry's presentation? So in case there's questions that pop up. Okay.
Absolutely.
Great. All right, well, let's hand it off to Sherry, and then we'll wrap it up with any final questions after her presentation.
So thank you very much. I'm happy to be sort of cleanup matter for our presentation today. I'm Sherry Shamblin, Chief Strategy Officer for Hopewell Health Centers, as I said, and I'm joining you from Athens, Ohio. And I don't seem to be able to move slides. So next slide, please. Our mission is access to affordable, high quality, integrated healthcare to all. Next slide. And as you can see, we really do have the southeast corner of the state. Our vision is a community where everyone enjoys a healthy body, mind, and spirit. We are a federally qualified health center and a SAMHSA credentialed certified community behavioral health clinic and certified through Department of Mental Health. And we really feel that integrated approach is really important and critical to success. Next slide. If you are in 2021, Hopewell had 30 clinics in 9 counties, very extensive early childhood services in an additional 10 counties. We have 5 school-based clinics, behavioral health partnerships with additional 22 school districts. We serve 39,000, give or take, clients. 15,000 of those are behavioral health. And as you can see by the pictures there, our clinics vary and are quite reflective of the communities that they're in. Next slide. We provide a full continuum of ambulatory primary care services, dental services, basic dental services, a full continuum of behavioral health services, and as I said, pretty extensive early childhood services to form an integrated whole. Next slide. If you've been in our southern part of the state before, you know that it is a beautiful, beautiful place. People are tied to the land. The farm on the right is actually the farm that my great-great-grandfather came from Pennsylvania to start. I live about a quarter mile out the road. And so for me, those roots and ties are very deep and part of the resiliency I see in my community and region. Next slide. We have a proud culture that emphasizes humbleness, community connectedness. I feel that we have a proud heritage and we're good at working together and we're good practical problem solvers. Next slide. But we do have challenges, and a number of our counties meet the criteria for distressed or at-risk counties. We're very rural, and that means that a lot of the infrastructure that may exist in other areas aren't necessarily in place or are spotty, like broadband and cell service. And we have high rate of poverty. Next slide. We have behavioral health challenges as well. Substance use disorder rates are higher than state and national averages for most of our counties. And health departments over and over again identify lack of access to behavioral health services as one of the major gaps and needs. Next slide. And as Tony pointed out in his map, a number of our counties, Jackson, Meigs, Gallia, and Hocking, are those very dark green counties that were on his map. We are a workforce shortage area for pretty much all healthcare, but particularly mental health. And on those Robert Wood Johnson rankings, we would fall in the bottom 25% for health outcomes and health factors. Next slide, please. We embrace those challenges at Hopewell and say complex challenges require complex solutions, that if it were easy, there'd be nothing for us to do or somebody would have done it already. Next slide. So Dr. Blankenship and Dayton have pillars. We have built a pretty comprehensive model on SAMHSA's 8 dimensions of wellness because we really do want to move beyond just treatment, but really promoting that wellness in our communities, because we feel like strong individuals form strong communities help individuals be strong, and that will be how here in rural Appalachia we can address the disparities that we face. So we try to link each of these dimensions to a component that we're offering, or we are partnering with a sister or brother agency to offer. And so that we can fill this in, and we just continue to work to fill in these dimensions. Next slide, please. Through that, we've had a lot of, I feel like success since we formed through our merger in 2013. And, I was trying to reflect on how for the purposes of this presentation. And so I'll move to the next slide, please. Part of it is actually balance. Sometimes you get your best feedback from those outside your organization. And we had the dubious privilege of having our Joint Commission survey team come for the full week because we're so big. We take a full week now at the end of July. And the behavioral health surveyor was quite complimentary and said, Hopewell was one of the few places he might consider working. And he kept really challenging us to think about why we were able to meet the things that we were able to do. And some feedback he gave us that I'll share is that, just striking that balance of really listening to communities and what they feel they need and trying to respond to that, not saying, here's what you need, or here's the Hopewell model, but really listening intently and then joining to problem solve, while at the same time holding ourselves accountable to structure and evidence-based processes and procedures and always improving quality, which is sort of a layer. I think sometimes in our rural areas, we sometimes feel like, well, something's better than nothing, which is certainly true, but that continuing to hold ourselves accountable to continuing to improve with our communities, I think is a nice balance. Next slide, please. Along with that conversation with that surveyor, and I was again thinking about how do we strike that balance, we've really created a company-wide culture of helpfulness at all levels. All of our main leadership are from the region, so we are of the culture, and that humbleness rides through and that hope to be helpful. And so we, if somebody even within Hopewell is approaching me with something, honestly, I usually say, how can I help? Or one of my team members does the same. If we're in a community meeting and somebody mentions a concern, a challenge, an else, we really just, how do you think we can help? And if we can pull that off or help someone else in the community pull it off, or think of a path forward for all of us, we're there. And so that is something that I'm quite proud of that we have as a company culture. Next slide. that's led to a number of things that match an awful lot of things that were mentioned by Mental Health America, right? That we try to embed services in the community. I'm a counselor by training about 20 years ago. And even then, I came out of graduate school saying mental health does its best work when it's outside the clinic. And we worked very hard to do that. We have a lot of school-based services, as I've said. We have, through Ohio Rise and working with some of our local partners, we assessed who might be the best CNE care coordination entity. And we decided that wasn't us. There was somebody better positioned for that, and that we wanted to continue to work on building out the continuum of services. So we've added mobile response stabilization services and mobile crisis. And then another thing we do is, again, we don't try to build everything within Hopewell. We don't have that capacity. We also have so few providers here. We don't want to compete with anyone. We want to uplift all of us together. So a lot of times, if there's an organization that is doing something unique, those niche services, perhaps that Dr. Blankenship referred to, we've set them up as Medicaid subcontractors or tried to use our billing and business structure so that they could continue and grow. So that leads to the next slide, which is that we have really genuine, strong partnerships. This doesn't even begin to cover the partnerships we had. You wouldn't be able to read the slide if I did, but just to represent that there is nothing that our agency has done that we've done alone. Not a single thing that I could think. I was trying to think of them, and I couldn't think of any. We like that. Like, we like the fact that we can join with others and lift others up. And I use this genuine and strong partnerships because a lot of times in business, you hear the word partnership for people. These are real relationships of person to person that mean that sometimes we take a way back seat. We're not even in the car. Sometimes we're just trying to figure out how we can support something going forward. We cheer when all of our other, organizations in our area are successful doing something, and they do the same for us. Which leads me to the next slide. And thanks to a partnership with the Appalachian Children Coalition, which was a couple of years ago, was a little group that I was invited to join in on, and they needed a business structure until they could get their 501c3. So we said, we think we can do that. So we worked and figured it out. And now, they're doing great things in terms of pulling together things in the region and advocacy. They asked, when they were pulling together their ideas, what were some projects that might fit. I learned after I submitted the slide that actually trailed its way to the Ohio Children's Hospital Association. So I now had people who I have never met in my life, and an entity I hadn't heard of until then much, also joining us in our work and partnering, which is very humbling. But thanks to the Governor's Pediatric Health Initiative and ARPA funds and all of this collective partnership, we are able to move forward our work in a couple of ways. Next slide. So we are using ARPA funds to help with an integrated school-based health clinic for Eastern local schools. This is a small school district in Meigs County. They have about 830 students, 100 staff, and in that surrounding zip code, there are about 3,500 individuals, but only 23% have access to healthcare services. We had behavioral health services providers going to the school for many years, but were approached in 2020 they had funds that they wanted to help build out a clinic if we could help provide the service providers and the equipment, and we did that. And then they had a dream altogether of creating space that the behavioral health staff could be joined there, and a small dental operatory that could serve that community. So that is what we mean by integrated school-based clinic, and that opened as a clinic in 2021. And the open house ribbon cutting that you're seeing is for the expanded space that includes behavioral health offices and the small dental operatory. Next slide. an integrated school-based health clinic for Nelsonville, York. Similarly, we have had behavioral health service providers going to Nelsonville and seeing kids on site, but no space. They approached us about could we partner with them on a health clinic. And the superintendent had a great vision there. There's a suite that was the administrative suite. He's converting to a health clinic space. It is converted. It will be opening in just a few short weeks. But not only for our behavioral health staff and a primary care nurse and nurse practitioner, but plans to embed his own specialty clinical staff, like the school nurse, the OT/PT, speech language therapist, so that there truly is an integrated, seamless approach between the two organizations. And that school serves 1,200 students, 80 staff, and about 4,400 residents in the area. 26% are the only ones that are have access to health services. Both of these school clinics will serve the communities as well as the student population. Next slide. We will be expanding and opening a child crisis stabilization unit in Gallia County, 16 beds for children and youth ages 8 to 17 who are experiencing mental health crisis and need short-term interventions. Very common problem in our area is that if a child or youth needs the next level of care and can't be maintained in their home, very often they are having to leave the area to be hospitalized or stabilized, and then they lose connection to their care network, you know, their family or their friends. And again, that I can't overstate the connected and groundedness that comes from the land for folks that live in my area. So we are managing the crisis stabilization unit at Integrated Services for Behavioral Health as a local partner that is making inroads and increasing access to behavior to residential. And so we're hoping that working together, we're going to have a good continuum of care in our region. Next slide. Part of that continuum would include day treatment or youth partial hospitalization program. We have a program called REACH. It has a main base in Nelsonville, but that is an hour away from the far ends of our continuum, our region that we serve. So we last year opened a smaller program at another location in Washington County to get that end. And through these funds, we'll be doing one in Cheshire, which is sort of the Gallia Makes area, and would take care of that southern end. And that we hope to have about 20 to 25 youth served in that satellite. The main campus serves 70 youth. So again, we hope that adds to our continuum of care that will allow us to keep youth in our area and be supported. Next slide. Although it's an irritating song to some, this is sort of my mantra. Everything's awesome. Everything's cool when you're part of our team. And I just really appreciate being able to represent all the teams that I'm a part of, and to be able to personally thank those around the region, the state, and others that have helped join our team so that we can continue our work. Next slide. And so thank you, and thank you to Health Policy Institute of Ohio and Amy for being able to share this with everyone today.
Now, thanks to you, Sherry, I'm going to have that song going through my head for the rest of the day.
It
Well,
gets back, doesn't it?
It does, that's for sure. So if there are questions for either Sherry or Dr. Blankenship, please post those in the chat box. I know I learned a lot from both of you in your brief presentations. Very, very helpful to hear how that initiative is being operationalized in several areas of the state, and your unique approaches to serving your communities. And Dr. Blankenship, it seems as though you might have joined us from vacation. So we particularly appreciate that.
Oh, I'm happy to do it. I just feel like this is really important, so I was excited to be part of it.
Yes, thank you.
Amy, while we're waiting on questions to come in, I'm going to launch the poll questions for Tony, Dr. Blankenship, and Sherry, and then I'll let you move us along.
All right, great.
So,
well, yeah.
those of you
Go ahead.
still with us, please take a look at the poll questions. Don't forget to scroll and answer these questions for us. And Amy will have some closing comments as well.
Okay, so again, answer all three of those poll questions in the second set here. We're very glad that so many of you have stayed with us through the end of today's forum. We hope you are coming away from today with a greater sense of the challenges facing youth related to mental health, as well as ideas of strategies that you may be able to implement or explore in your communities or advocate for at the state or local level in terms of policy change. On that topic, Alana, are we ready to close the poll?
Sure,
And I'm
we can
not
move on.
okay. Let's see. I do see a question here. The question is, the 8 pillars are excellent, but an area of possible need could be a subcategory under finances or employment. Is a partnership with an area legal aid organization to provide access to civil legal services through a medical legal partnership model. So I'm not sure that there's a question there, but an idea for folks to consider. And let's see. Any other questions? Oh, someone asked if we can copy the chat and send it out. Alana, is that possible?
I can do that and post it on our webpage.
Okay, great. Thank you. All right, well, let's go to our last slide, Alana. And thank you again, Sherry, Dr. Blankenship. We very much appreciated your time with us today. I mentioned policy change. I think you've heard of several ideas that today that are rooted in policy. Please remember that there's always many ways that you can weigh in on the policymaking process, both through talking to your legislators or to folks who work in state agencies, local elected officials like county commissioners and city council people. So remember that they exist to serve you. You are their constituents. They want to hear from you. So please weigh in on your concerns regarding youth mental health and other health challenges by writing letters, providing stories of impact, inviting your local elected officials to come and visit your program, tour your facility, build a relationship with your policymakers before you are asking for something specific, so that when the time comes for you to have a specific ask, they know you and they trust you as a resource. I guess I would be remiss if I didn't mention today is an election day here in Ohio. So that's another key way that you can influence the policymaking process, and that's through voting. Please, I think you will have faced no lines at any polling location today. So please get out and vote. No election is insignificant, and it's an important way for your voice to be heard. Thank you again to all of our speakers for spending time with us today, and for all of you who participated in the polling questions throughout. I think we have one final poll question, is that right? Okay.
We've got one last set, so this one.
Okay, one last set. Oh, about overall. So overall, how would you rate the quality of today's forum? And then how likely are you to use the information presented today in influencing the policy making process? give you a couple seconds here to respond.
And don't
And I
forget to
know-
scroll. We've got a couple more there for
Oh
you.
gosh, see, and I did it again. I did not scroll. Okay, so then the third question. See, were we successful in making sure that there was a diverse range of backgrounds and perspectives presented today? And then overall, was our forum objective and balanced? Was it accurate and credible?
So we'll just give people a few seconds to do that, and then I think we will close out.
So
Amy,
we're making
I'll-
Alana very happy right now because it is 1 o'clock on the dot.
I'm going to let you just remind people that the slides are already up on our website for all of the presenters. Amy, you've got some other things you've got on your,
I do.
maybe.
I say thank you for attending on the online forum today. Please share any feedback you might have.
Yeah, so
Um,
there on our website, the events page of our website, there is a little box under resources where you can directly type in your feedback into
Oh,
one of our online portals. So if you have comments that you want to share with us or with our speakers, please do that on our website.
oh, okay. Yeah, I see your note about feedback about today's event using the link on our events page, but I don't think I knew about the special way we could gather feedback. So thanks for that, Alana.
It's new, it's the first time.
All right, thank you, Lois, for your comment. You're always so positive. We were glad you were here. Yes, and I see Paula Hicks Hudson has also reminded everyone to vote. Thank you very much for that. Appreciate all of your attendance. Hope you have a great day. Take care.